Welcome to Pulse Pressors, where critical care gets crystal clear. BIS and Train of 4 monitoring represent two complementary tools that protect patients from both ends of the sedation spectrum. BIS quantifies hypnotic depth, while Train of 4 quantifies neuromuscular blockade. Used together, they prevent the two most dangerous outcomes: awake paralysis and unnecessary deep coma. This presentation outlines how experts integrate these tools in both the ICU and OR to deliver safe, humane, physiologic care. BIS is a processed EEG score that reflects the level of cortical hypnosis. The number does not measure pain, paralysis, or vital organ stress, only hypnotic depth. The clinically relevant target during deep sedation or anesthesia is BIS 40 to 60. Values outside this range help identify under or over sedation, but always in context. BIS is an adjunct, never a substitute for clinical judgment. A 2024 meta-analysis showed that BIS-guided anesthesia improves efficiency, faster emergence, less anesthetic use, shorter PACU stays, and modest reduction in post-operative cognitive dysfunction. BIS does not eliminate delirium or guarantee cognitive protection. Rather, it tightens hypnotic titration and prevents unintentional overdose of anesthetics. It refines anesthesia, not replaces clinical monitoring. In the ICU, deep sedation often drifts into coma without detection. The CHEST randomized control trials revealed that patients managed by clinical exam alone spent large amounts of time with BIS less than 40, levels indicating deep unintentional hypnosis. BIS-guided sedation decreased drug exposure and improved delirium-free, coma-free days in patients requiring sedation for greater than 24 hours. BIS does not replace RAS, but when movement is absent or suppressed, it becomes essential. BIS is vulnerable to false interpretation. Neuromuscular blockade lowers EMG activity, falsely decreasing BIS even when the patient is awake. Hypothermia, circulatory arrest, or infants' immature EEG patterns distort readings. Ketamine, nitrous oxide, and high-dose opioids uncouple BIS from awareness. BIS must always be interpreted with clinical context and must never be used alone to justify sedation reduction in paralyzed patients. Train of 4 monitoring describes the degree of neuromuscular blockade. As twitches diminish from 4 out of 4 down to 0 out of 4, blockade deepens. But the modern gold standard is the Train of 4 ratio, which must reach greater than or equal to 0.9 before extubation to prevent residual paralysis. The Train of 4 ratio is calculated by dividing the amplitude of the fourth twitch, T4, by the amplitude of the first twitch, T1. When no twitches are present, we switch to post-tetanic count, or PTC. A higher count indicates a patient is closer to returning to measurable Train of 4 activity. Quantitative Train of 4 far surpasses subjective palpation and is the expected practice standard. According to the 2023 ASA guidelines, all patients receiving non-depolarizing neuromuscular blockers require quantitative monitoring. Subjective qualitative assessment is insufficient because clinicians cannot detect fade until the Train of 4 ratio is already dangerously low, approximately 0.4. Extubation requires documented Train of 4 ratio greater than or equal to 0.9 at the adductor pollicis. Anything less is unsafe. Paralysis without adequate analgesia and hypnosis is a catastrophic clinical failure. Patients experience terror, suffocation, and vivid recall. Movement disappears, but awareness persists unless deliberately prevented. Sedation must always precede and accompany paralysis. BIS cannot be used to justify lighter sedation during NMB. The default assumption must always be, a paralyzed patient may be awake unless I intentionally prevent it. In routine ICU care without, RAS is the primary tool. For deep sedation, BIS helps avoid oversedation. Once paralysis is added, RAS becomes impossible. Train of 4 guides paralysis depth, while BIS helps estimate hypnotic depth, but only as part of a broader sedation strategy. Sedation should not be lowered solely based on BIS. The patient's inability to move requires deeper vigilance. Train of 4 targets differ by setting. In the OR, moderate blockade is typical, and full recovery with Train of 4 ratio greater than or equal to 0.9 is required before extubation. In the ICU, Blockade is used sparingly and intentionally for ARDS, dysynchrony, or TTM. Deep block, 0 out of 4, may be appropriate but must be matched with PTC monitoring and daily reassessment. Neuromuscular blockade must always be time-limited. Train of 4 monitoring has pitfalls. Facial nerve monitoring recovers early and can falsely suggest readiness for extubation. Qualitative train of 4 cannot detect fade until train of 4 ratio is dangerously low. Non-depolarizers cause fade. Depolarizers cause uniform depression. Edema, poor electrode contact, hypothermia, and technical errors distort results. Strength tests, head lift, hand grip are insensitive. Quantitative train of 4 is the solution to all these issues. The reason this topic matters is not academic, it is human. Awake paralysis causes PTSD, anxiety, and lasting harm. Deep, prolonged coma leads to delirium, weakness, and prolonged ventilation. BIS and train of 4 prevent both extremes. They guide safe, humane care that considers both physiology and the patient's lived experience. Expert practice follows a disciplined sequence. Confirm the need for NMB, provide analgesia and deep sedation first. Initiate NMB only after achieving hypnosis. Titrate paralysis using quantitative train of 4. Use BIS as adjunctive monitoring during deep sedation. Reassess the need for paralysis daily, and require train of 4 ratio greater than or equal to 0.9 before extubation. This approach protects both the patient's body and their mind. This is Pulse and Pressors, reflecting on the marvels of the human body. Subscribe to stay sharp.